happened because I couldn't imagine that in this scientific level we can have this. Okay, let me mention again that this is our second meeting, and we are honored by the lecture by Professor Lester Gottsman on the anismus from the surgeon's point of view. He highlighted some important points to the lack of correlation between self-report symptoms and ROM4 criteria. I'm very happy that he mentioned that in his lecture, that we are using forms, like you have to let the patient ask or ask him relevant questions which can help him to express himself. Definitely the methods used are manometry, balloon expansion, difficography, but unfortunately, Pisano et al. Said that we don't have correlation between our lab, between the manometry, asked why do the results from manometric testing frequently poorly correlates with clinical outcome, and why it's used so fiercely debated in the literature, either prominent test or interpretation. Actually, the last question was the motivation for me to start thinking we have to have a model. And as I said, they tried in the past to use mechanical models, but I think this model, which I'll present, is what they use in the urology happily since 70s. And this was the first paper, second paper, and the work of Professor Peter Petrus confirming the role of flow equation in this, and this is a book available. And this a paper by a very respected group from London University citing the first paper. And I said that the flow equation as a model has solved our problem, starting from the definitions, review of literature like the review by Lester, and can solve controversies or have questions. It can work an arbitrator. I remind you again that it's not a theory, it's a model. So if we accept this model, we have to look why we have those controversies and if it can solve it. In the past, they tried to do pressure measurement interaction, and this had failed totally to explain continence, defecation, or disease like inner incontinence or obstructive defecation. And the first look at this equation is that its flow equals pressure, which is in the rectum, divided by the anal canal resistance. So it's a pressure resistance interaction. The manometry, the bad reputation manometry, because we used it to measure the anal canal pressure while we have to measure the interrectal pressure. Whether this is the best way to measure the interrectal pressure or not, but this is the available. And actually, I'll show you that in our lab, we had a correlation with the patient symptoms up to 97% in obstructive defecation and in 92% in incontinence. I mean, it's a very, very high correlation. So we have to trust, at least at this point, the interrectal pressure from the flow equation point of view. But what governs the resistance? Like any tube, whether it's a biological tube or rigid tube, it's the length and diameter. Diameter being the most important because it's raised to power 4. Definitely the contents or consistency, which we call consistency, is the dynamic viscosity. And this can explain why the resistance is lowest to the gas, then to liquid stools, then to solid stools, and even hard stools is difficult for every normal person. We can measure the resistance easily from this lateral view, whether we use traditional difficography or MRI difficography or NCT difficography, like what had been explained to me by Ilario. And this is how to standardize a colorectal lab. The main aim of this society is to have a standardized colorectal lab, because we can do research between us, we can do international research, we can do multi-center research without having this standardized lab. Using the flow equation as a model, we have to remember that in incontinence, we have passive incontinence, which is governed by interrectal pressure during rest, urge incontinence, which may be governed by during squeeze, or maybe stress incontinence during cough or Valsalva maneuver. We have to test defecation by pushing on an empty rectum. We have to test rectal inner inhibitory reflex. We have to test the sensation, first urge and intense urge, endurance squeeze, and balloon expulsion. We can look at the upper curve. Lester said in his paper that we use one of the pores to measure, deepest pore to measure the intrarectal pressure. So we have simple mechanical primary factors. It's the flow, whether it's incontinence or defecation. It depends on, it increases as we increase interrectal pressure. This is understandable to all of us. And it increases if the diameter increases. And this is the most important, being raised to power 4. And that's why we put our fingers to see if it's an open air canal or tight. Rest, squeeze, even cough, and during defecation. And flow decreases as we increase the length, because flow increases as we decrease the length. We know that defecation we have to decrease the length, while if we want to prevent flow, we have to increase the length. Dynamic viscosity, as we said, is important. And in our work, we try to remove one of the factors, which is dynamic viscosity, by using air, water, and barium sulfate paste in order to have a constant. Can this equation solve our problems? We can see from this equation that we can gather rectal propulsive activity with the anal canal resistance, because one of them is in the numerator and the other is denominator. But the term obstructed defecation is more appropriate to have both. If we look at the anal canal pressure, we can't see it in this equation. So this explains why the bad reputation of the manometry. The anorectal angle doesn't show itself primarily in this equation. It's an indication of the action of pubic rectalis, but it may be present while the anal canal is open and short. So it's not an indication, and all mechanical models denied its role. Perineal descent, when I started my work and published my first paper, I said it doesn't show itself in this equation, but I'll show you a very interesting paper from Italy, which had changed my mind in this. Also, as I mentioned, frequency of anal incontinence, should it be included in this particular evaluation? Because frequency may change with change of other things in the body. If we have, for example, as I said in the previous lecture, if we have stress incontinence, it's increased the frequency with the cough if we have a bronchitis or something like this. So it's important for the patient, and we have to put it in a separate category in a composite evaluation. We can see that it's very easy now. We don't have to calculate anything, just length, diameter, put the length and diameter, and you can have resistance, and you will have result, as you will see, and we can add the interrectal pressure, and then we can have a diagnosis. Also, this normogram is a presentation of the anal canal diameter in the transverse X axis, and in the Y1 we can anal canal length, and in the Y2 we can have interrectal pressure. And these are the curves which separate 4 zones. The first zone is the normal defecation, all will be normal after correction of the mechanical factors, as we will see in later on. And in stage 2, 3, 4, we have a problem in the physiology, whether in the aneurysms or in the rectal inertia, and this will put the patient into zone 2 for soft stools, zone 3 for fluid stools, zone 4 even for gases. So this is very important. Rectal pressures are considered surrogate of propulsive forces. I do agree. Weak propulsive forces are categorized as anismus. No. Anismus is failure of relaxation of the inner sphincter from the flow equation point of view. And we can see that the rectal pressures are considered as surrogate of the propulsive activity of the defecation or continence. Weak propulsive forces are categorized as anismus, were recorded by proximal ports. Yes, as I show you, it's reported by proximal parts of the manometry. These are recorded. Low pressures are interpreted as resulting from a weak rectal propagation force. Definitely, at this point, Lester said it's not the pressure. We have to measure something else, but we can do research on this together. But in our lab and from the flow equation point of view, pressure still holds good for regarding the correlation with the patient's symptoms. This is very important. This what we had mentioned about the perineal descent. I do agree with the first statement that laxity of pelvic floor occurring with abnormal perineal descent, not rectocele from my point of view, and I tell you why from the flow equation point of view, causes diffusion of pressures during Valsalva. Yes, And the first statement had been proved by the group from Italy, but the rectoceal, we can see patients with rectoceal with good interrectal pressure. There is a maldirected flow studied in our lab, as I'll show you. This how to select patients with rectoceal for surgery. There were 10 patients. Before surgery, this was their reading. 4 of them in zone 1. This means that they will be normalized after surgery. This is how to predict even outcome. And in the other 6, it will be, they will still suffer from obstructive defecation, whether soft stools or liquid stools. We can see that it's very easy to put the patient on this curves, and this is the close view of this. And let's see what happens with the rectoceal. Is it a dissipated force or a small directed flow? A small directed flow, we can see the resistance in the rectoceal in all symptomatic patients is much lower than the resistance in the inner canal. Some of them have aneurysmas, they have very high resistance, but others, even with a normal inner canal, these stools are directed first to the rectoceal. That's why I used to test them for their benefit from surgery by sham operation, doing a tampon in the vagina and ask the patient if she feels better while she is defecating, because this means that if I correct this rectoceal, their inner canal and rectum will be normal. The classic manometric definition of type 1 aneurysmas, paradoxal contraction of the sphincter, is 20% decrease from the baseline of external anal sphincter during Valsalva, yet this occurs in 30% of healthy volunteers. That's why we don't rely on pressures. Whereas all types of aneurysmas can occur in up to 80%, 87% of healthy people. The explanation of this can only be seen with the normogram, because in this normogram, we define what is aneurysmas. Minimum will have inner canal length 2 centimeters, and canal 2 centimeters, and below this line, there is aneurysmas. We can see that the aneurysmas group include patients in zone 1 of normal defecation. Why? Because they can increase their interrectal pressure. It's an integrated system. This can explain why normal people can have aneurysmas in their investigation while they don't have problem in defecation, because they build a good pressure in the rectum without much straining, and they can defecate. And we can see this line is the separate between the normal interrectal pressure during defecation and rectal inertia. We can see that also many of the patients with rectal inertia can still have normal defecation, because they can decrease the inner canal length and increase inner canal diameter effectively. Because of this, their inertia is not effective or appear as obstructed defecation. We can see those lines, but when we have both, all of the patients can see between the area of combined, all of them lie in the zone 2, 3, and 4 of obstructed defecation, but because there is no compensation. We take our patients as control from zone 1, who are defecating normally, while they are mixed population. They are formed of some patients with compensated aneurysmas, some of them compensated rectal inertia, but our normal control should be based on this normogram, should be have mean interrectal pressure more than 50 and have inner canal resistance to the right of this line. This is my definition and grading of rectal inertia, first published in the first paper, and it's available in the book. And we can see that here the aneurysmas patient, some of them lie in zone 1 because they are compensated by mean interrectal pressure. And again, this is how we can predict this. There are 2 patients almost the same. They have anterior rectoceal interception, and one of them, if we draw the line between the inner canal length and diameter and the interrectal pressure, they lie far in the zone 1. They will be improved if we remove their interception and rectoceal, if their anatomical factors, while the same defecography almost from the lower graph, we can see that no, if we correct their apparent anatomical problems, they will remain, have some obstructive defecation, even in zone 3, which is obstructive defecation to fluid stools, and we have to tackle their aneurysmas whether with, for example, biofeedback or Botox, and we have to tackle their rectal inertia with medication or even resections. So without thoughtful certification, reams of accumulated physiological data altered by anatomical variability may bias the data with subsequent inaccurate diagnosis and inaccurate treatment. Only with thoughtful assessment before testing can the proper testing be ordered and understood. I do agree in this statement by Lester, but thoughtful assessment is very important, but we can think of thoughtful assessment before the era of integrated coloproctology and thoughtful assessment or in the era of digital coloproctology. We have now normograms which can help us to diagnose patients with incontinence in numerical way and see what is wrong, length, diameter, or anything like this. We can have this again in obstructive defecation. We have something we can see on paper. You don't have to think much about it. And we have the flow calculator. You can see how easy it is. If you put in a canal length and diameter, these results indicate no aneurysm. This is what happens when you use this calculator in this particular patient. These results indicate aneurysm, so we have to tackle this before correction of any of the anatomical factors. If we add the interrectal pressure, we can have this result, and you can see by yourself obstructive defecation to watery stools. You can ask the patient to have obstructive defecation to watery stools. You can say yes or not. Sometimes they drift into no soft stools because I don't have diarrhea too much or something like this, but it's very accurate. And in this particular patient or subject, this patient either normal as a control or normal after correction of his apparent anatomical problems like rectus inception, colonic inertia, mechanical obstruction, or hard stools. As I always say, this is Einstein, Albert Einstein saying, knowledge is power. If we have more information, we can have better thoughtful thinking. Thank you.
Thank you, Professor Ahmed, for this amazing lecture.
Thank you. It's open for discussion. If anyone, Professor Lester, do you have any comment on this?
No, it's a very thoughtful approach to the problem. I think at best you're looking at which patients would benefit from surgery and which wouldn't. I mean, my approach to rectus surgery is one, the symptomatology, and two, ask the patients to, I do all my rectus surgery through the rectum, not the vagina. It's much more durable and better operation. Having said that, I ask them to splint their, the rectus seal and see if they can defecate. If they can, then that answers the question for me also. But your approach is very unique and very thoughtful.
I would like to, if you have the investigation of one of your patients, and after the permission of the patient, you can send this to my WhatsApp or to Mahmoud WhatsApp, and you can make the calculation and you can see first. So don't change your decision. Just let us suggest what we have, and then you can build some confidence in the technique of calculation. It takes 3 to 5 minutes. And again, I would like to say that Hilario from Brazil, he sent the first case to me, and he did that. After that, his second calculation. Actually, it's very easy. He had experience, and he told us his experience in the last lecture that it's easy and informative. If we combined our efforts to evaluate our patients, we can, by the end of the next year, we can have hundreds of cases. We can see the correlation outside our lab, and you can see if it's useful for predicting outcome, follow-up of the patients or not. I mean, this is a model, not a theory, not anything else.
Can you further elaborate how you differentiate contractile pressure from Valsalva effects?
Yes, I used in the early, I used to do it myself, and then Dr. Mahmoud is doing this for me, but I'm revising every single case with him. Actually, there are many ways. In the early period, I used to put EMG on the abdominal wall to see if the surface EMG, see if there is contraction of the abdomen, and I instruct the patient to stop straining from his abdomen and try to defecate from below. And I found that there is compensated rectal inertia. And we can see this even from the curves. If we see the manometry curve, which I presented, it's spiky. If you see this spiky, hectic, spiky curve, most probably the patient is straining from his abdomen. You can put simply your hand on his abdomen and see if he is straining from his abdomen or not. In the urology, I used to be a urologist and worked with the urodynamic machine early in 1982. And we used to put intrarectal balloon to see the effect of straining, and we subtract the pressure recorded in the bladder, the rectum from that in the bladder to have the pure bladder pressure. We can't do the reverse because it's invasive for the urinary system. It may carry some risk, or the patient refuses. And I think the best way is to put our hand on the abdomen to see if the straining comes from the abdomen or it's the rectum.
Okay.
Just right. I mean, listen, it's risk-free, and I think Ilario may have more cases even to share with us. Do you have more cases, Ilario, to share with us?
Yes, I do. I have a lot of cases, and the flow equation, it's a very new thing to me, but it has a lot of value that I by now I will systematically include in my evaluations. And this kind of patients, the two speeches were amazing, were graceful. So it will improve our knowledge very much, and to the treatment of our patients, it will be very interesting. And about the descending perineum, about rectocele, I think it's about a disturbance of the rectal vector. The vector force is to another place, not to the anal canal. So it's the problem, and that's the way that I try to work. And that technique that I told you, Professor Ahmed, about the endoscopic rubber band ligation to rectocele, and it brings the anterior rectal wall to back, towards back position, and we can restore a little bit the vector force from the rectal, from the abdomen, from all the forces we can perform with our abdomen. And all the patients that they say to me that the effort to evacuate, it's very easily than before, much more easier than before, and the results, the outcomes are far better than I had before. And associated with the kind of biofeedback I perform, the results are improved too.
Where do you put the rubber bands? Could you clarify that? Where do you put the rubber bands?
The endoscopic and the anterior rectal wall, and with the colonoscope performing an rectal flexion, and do perform the three, and we call it the 3-point endoscopic rubber band ligation, and it restores that positions, and it restores the pelvic floor position a little bit, and the patient to evacuate, it's far better. But the only way to get these results is after the biofeedback to correct the anismus situation the patient has.
I think we have to address
afterwards
this.
I can show afterwards I can edit a video and show you. I can send through WhatsApp, and so easily it takes about 2 minutes to perform, and the results are quite amazing for sure. We have about 25 or 35 patients I have already done it, and all of them, they improve at about at least 80% from the rectocele symptoms and the defecation disturbance. So, but the first point we have to assure is that the evacuation disturbance is corrected before of this, and the aneurysms at any level of this, we have to try to restore it prior with biofeedback.
So
Yes,
this is a mucosal banding?
What, Professor, what?
You band the mucosa above the rectocele?
Yes. As we perform to internal hemorrhoids, so the point is I go a little upper, but when we can do it as if it was to the internal hemorrhoids, but I bend when we perform the endoscopy, the regular endoscopy, when we move the device inside and outside, we can see that mucosa that prolapses inside the device, and this mucosa that I bend. And the three bands are near, and we have no.
So may I ask you, what symptom
Yes,
are you addressing with the banding?
Sorry, I didn't understand you.
What symptom are you addressing with the banding? Specifically, is it easier for the patients to defecate, or is that feeling of bulging in the vagina gone?
Both, because the rectocele, the beginning of it comes from the vector force to the anterior rectal wall. The rectal vector force is not directed to the anus. That is the point. If you see the echography, you can see the vector force is to the front, is not to the anal canal. If we restore the anal canal to bring it back, we can redirect the rectal vector force towards the anal canal. It's easy to see in the echography prior and before the rubber band ligation. We can see it if we do the echography again. Here I perform through magnetic resonance, and we perform a tomographic echography.
So essentially, you're doing when I do a proctoplasty, I'm doing a more aggressive form of what you're doing by banding, essentially, and getting rid of all this redundant mucosa that falls into the anal canal and causes obstructive defecation.
Yes, my vision is to perform procedures minimally invasive. So I started doing it by endoscopic rubber band ligation, and the results are quite amazing. And back 10 years ago, I operated a lot of rectoceles by rectal approach, by perineal approach, by vaginal approach. And the results, in my opinion, are not quite very well. The dyspareunia, the patients develop. And so I thought a lot of a way to restore rectocele, and by this way, we can do a lot of things in the same procedure. So we can treat it, and the patients do not develop dyspareunia, and that's the way I will keep on doing like this. And soon we have to do these results published in the perineology soon.
Thank you.
Yes, I think
you're welcome.
We have a project, but we have to write it down on the use of flow equation to assess patients before and after biofeedback, because I always wanted to do this. But I think with the large number of the participants in this, members of this society, we can have very interesting results, whether the biofeedback, whether incontinence or constipation affects the parameters in the flow equation. The correlation between the symptoms before and after, and we can use it also for the new techniques like that of Ilario or the other technique by Professor Peter Petrus, the ligament approach. I mean, this is very interesting because we have a strong tool. It's objective rather than subjective, which can tell us what is good and what is not good. And at the end, we have to have happy patients. I mean, we have to have this good correlation between our lab and the patient symptoms so as to be confident that you are not a placebo effect. I mean, I think it's a very good idea to have new innovations. And one of the aims of this society is not only to spread the word of integration instead of the disseminated research in the coloproctology, because it's a highly integrated system, but also to embrace the innovations and do it in multi-central way so we can have large number of patients and objective data which we can publish. I would welcome everyone in this meeting and in the society to send even single patient to start with, and we'll send the calculator, the manometry, how we do it, the same picture of the 10-step manometry, and the other data which can help anyone to calculate, to make a calculation for himself, but just the first case just to show how we can do it, and the program we use for the measurement, because it's available on Google Store. It's Image Meter, which is an engineering tool, which is very accurate in measurement of the length and diameter with minimal error. Anyone of the audience want to have any question to Lester or to me?
Yeah, Professor Farag, Dr. Asif here.
Yes, go ahead, Lars.
Yeah, wonderful as always, and thanks for sharing your knowledge and experience with all of us. So just to know whether your equation can help us in diagnosing puborectal spasm. You know, one we can do is subjective assessment, and is there an objective assessment like your equation can help us in diagnosing puborectal spasm in the puborectal muscle?
Yeah, sure. The spasm is not important in itself. It's the diameter and length, so you can have residual spasm or spasm, and still there is a good contraction. Definitely, if you have strong spasm, this will affect the length and diameter. But let's now agree that you have the calculator. Did Mahmoud send to you the calculator or the normogram?
I sent them the calculator.
Awesome.
Yes, he sent this.
Yeah, so you can have a lateral difficographic view, and we'll send the program which is available on the Google Store to measure the length and diameter on your digital camera or tab, and then put the calculations, and you'll have the result on the screen. It's a result, anismus or no anismus. It's very, very simple, very easy. It's a fraction of a minute to put the length and diameter, and you'll have a result. So at this point, we can see that some of the cases have residual puborectalis impression, and still the patient can defecate normal because he has ability to lower his anal canal resistance. I mean, again, I have to remind you all that this is not a theory. It's a model. It's a mathematical and physical law which had been used successfully in urology and in vascular surgery and cardiac surgery. And we are applying this in the coloproctology. Of course, it wasn't an easy way to do it because I spent almost 3 years of sleepless nights every day from 4 a.m. to 8 a.m. until I could have this results and automation. The automation now will not make you make the difficult calculations. So just put the data you have in the difficography, and they will give you the result. I know that you don't have a manometry, but I'm thinking of something cheap and engineering like machine, which can help you in measurement of interrectal pressure without the complex and expensive manometry machine until we have this fundraising to equip most of the centers, at least with the manometry to measure interrectal pressure. And of course, difficography can be done easily, whether the barium difficography, MRI, or CT difficography.
Okay, let's arrange for another meeting to present some cases and make a live presentation with the equation, and Dr. Farag can assess the difficography or the length and diameter, and we can do put it on the equation and on the normogram, and then we can compare it with the symptoms and signs the patient gives, and to assess the normogram again, and assess the calculation, and discuss again.
Yes, I do agree, Mahmoud. It's a good idea. We can present one of our cases, or even every one of us can present a case, and we can discuss. Will be much more fruitful, even because we can exchange experiences. I ask you, Lester, to remain with us, even without being a member, but your presence is very important to us. We can make use of your experience. We can project some of our cases. Thank you. It's our honor.
My pleasure. My pleasure.
And we'll choose a proper time for US, because I know that these times are not suitable for the ordinary days. So we can arrange with Mahmoud the proper time.
This is actually good for me. This time is good for me, actually, because it'll be before my surgery on Friday, so it'll work fine.
Thank you very much, Lester. It's very brainstorming as we expected, and we hope that we'll meet again soon and discuss more about this very interesting problem.
Great. Thank you for including me. I much appreciate it.
Thank you, all of you. Thank
you, everyone.
Professor Farag.
Thank you, my friends. Thank you, my friends.
You are welcome.
Thank you.
Okay.